Hey, what's up everybody? It's me, your doctor friend Siddharth, and today we are going to talk about multiple myeloma. Let us discuss background first. Multiple myeloma belongs to a group of disease called plasma cell dyscrasia. Apart from multiple myeloma, plasma cell dyscrasia also include minimal change gammopathy of undetermined significance MCGUS, localized plasmacytoma, lymphoplasmacytic lymphoma, heavy chain disease, and primary amyloidosis. Multiple myeloma is known by various names like plasma cell myeloma, myelomatosis, Caller's disease. It is defined as monoclonal malignant proliferation of the plasma cell. This term monoclonal malignant proliferation is quite important here. If you understand the meaning of this term, then I believe that you have understood the concept of multiple myeloma. Here I have shown various blood cells that develops from the multipotent hematopoietic stem cell of the bone marrow, and our disease is here in the plasma cell. So it is the disorder of the lymphoid lineage, not the myeloid lineage. Normally what happens is, on receiving a stimulus, B cell proliferates to form plasma cells, and these plasma cells will produce immunoglobulins of all class and types. I want to stress here all class and types. Now before understanding what does this mean, let us first of all discuss about the structure of the immunoglobulin. Here in this particular diagram, I have shown the structure of the immunoglobulin. The long one is called heavy chain and the short one is called light chain. This half is the fragment antigen binding half and this half is the fragment crystallization half. This is the antigen binding site. The heavy chain in itself and the heavy chain with the light chain are linked by the disulfide bridge. If this heavy chain is of gamma type, then the immunoglobulin is IgG. If it is of mu type, then it is IgM, delta IgD, epsilon IgE, and alpha IgA. The heavy chain are linked up with the light chain of either kappa or lambda type, but never both in one particular immunoglobulin. One plasma cell will always produce one type of immunoglobulin. So if we have different combinations of different immunoglobulins like IgG kappa in lambda, IgM kappa in lambda, IgA kappa in lambda, IgD kappa in lambda, and so on, IgE kappa in lambda, then we have altogether of 10 possible combinations of the plasma cell. Whenever a B cell receives a stimulus, it produces the plasma cell of all class and types, and this is called the normal polyclonal response. But in case of multiple myeloma, the bone marrow gets stimulated to form only one clone of plasma cell. That is, it produces only one copy of plasma cell, and this single copy of plasma cell will form the single copies of immunoglobulins. And therefore, this is called monoclonal response. The monoclonal response can be of various type of immunoglobulins, but among them IgG is the most common form and is found in 53% of patients of multiple myeloma. IgA is the next common form, found in 25%, and IgD is found in less than 1% and it is least common form. IgA is the most common form of immunoglobulin in multiple myeloma, and IgD is the least common form of immunoglobulin in multiple myeloma. This is important for multiple choice question. Now, this monoclonal immunoglobulin is called M protein or paraprotein. In some cases, malignant cell may produce only free light chains, and these free light chains have got low molecular weight and so can easily pass through the glomerular basement membrane and can be excreted in urine. These light chains present in the urine in patients of multiple myeloma are called urinary M protein, also known as Bence-Jones protein. The term Bence-Jones protein, which is the urinary light chain or urinary M protein found in the case of multiple myeloma, is important for multiple choice question. This is the densitometric tracing of the normal serum protein electrophoresis. This is albumin, this and these are alpha 1 and alpha 2, this is beta and this is gamma. There are many different immunoglobulins in the serum, therefore their differing mobilities in the electric field produces a broad peak shown here. But in case of multiple myeloma, since there is a single clone of immunoglobulin being produced, therefore there will be a tall peak in the gamma region. This tall peak in the gamma region is also known as M band. But why do these happen in case of multiple myeloma? Let us discuss about the etiopathogenesis. The exact cause is not yet known. However, we have deduced various associations of this disease. It has been found to be occurring in increased frequency in those exposed to radiation of nuclear warheads in World War II. It is seen more commonly in farmers, woodworkers, leather workers, and those exposed to petroleum products. And it has also been found to increase in incidence with age, with the average age of incidence being 70 years, that it is uncommon below 40 years of age. Various chromosomal alteration has also been found to be associated, and I have shown here one of such alteration. This is the chromosome number 11, and this is chromosome number 14. In the chromosome number 11, at this locus is the cyclin D gene, and in chromosome number 14, at this locus is IgH gene. In multiple myeloma, there will be the translocation between chromosome 11 and chromosome number 14. Besides, there are also the translocation between chromosome number 4 and 14, 14 and 16, and likewise there is also the deletion of 13q14 region and 17p13 region. However, the most common chromosomal abnormality is the translocation between 11 and 14th chromosome, and the translocation between 4 and 14th chromosome has got worse prognosis. These two are important for multiple choice question. Now let us discuss about the clinical features of multiple myeloma. There are 5 broad clinical presentation of this disease: bone pain, lytic bone lesion or pathological fracture, infection, renal failure, neurological symptoms, and anemia. The bone pain is the most important one, and it is found in 70% patients, and it mainly involves flat bones. The flat bones that it involves can be either spine, ribs, skull, or hip. And the involvement of spine is the commonest, and this is important for multiple choice question. The bone pain worsens with activity, unlike the metastatic bone disease in which it worsens more at night. If the bone pain is persistently localized in one particular region, then that may indicate the pathological fracture. And the involvement of vertebra can lead to the spinal cord compression or kyphosis. Involvement of skull can give the skull a paper pot appearance. I have shown in this diagram the paper pot. There are small holes. Similar holes can be seen in the X-ray of the skull. This is called the paper pot appearance of skull. Now let us talk about the pathophysiology of the bone pain. The activated plasma cell, which is the myeloma cell, produces various kinds of cytokines like interleukin-6, tumor necrosis factor, receptor activation of nuclear factor kappa B ligand RA and KL, and macrophage inhibitory proteins. These cytokines will activate the osteoclast, which are also known as bone-eating cells. The myeloma cell also produces a factor known as DKK1, also known as DKOF1. This suppresses the osteoblastic new bone formation. Now, since osteoclasts are activated and osteoblasts are inhibited, the bone resorption takes place, and that is responsible for lytic bone lesions and the features of hypercalcemia. There is the production of high amount of immunoglobulins in multiple myeloma. Still, the person is predisposed to various infections like pneumonia and pyelonephritis. Why this happens? Because although total immunoglobulin level is increased, but they are ineffective monoclonal immunoglobulin. Likewise, there is also increased catabolism and decreased synthesis of polyclonal immunoglobulin. Similarly, granulocyte migration is found to be not as rapid as normal in patients with multiple myeloma, and abnormalities of complement function has also been seen. These are the reasons why the person is predisposed to infection. The third clinical feature is renal failure, and the renal failure is due to the tubulopathic effects of paraprotein or light chains, recurrent pyelonephritis, local infiltration of the myeloma cells, hypercalcemia causes nephrocalcinosis, and the frequent use of NSAIDs for bone pain. The neurological symptoms are weakness, confusion, depression, and lethargy, and it is due to anemia and hypercalcemia. Headache, shortness of breath, vertigo, retinopathy, visual changes are due to hyperviscosity of blood. However, the hyperviscosity of blood in itself is an uncommon feature of multiple myeloma, and this is important for multiple choice question. There is radicular pain, loss of bowel or bladder control, and it is due to spinal cord compression because of lytic bone lesions. And similarly, carpal tunnel syndrome and other neuropathies are due to infiltration of peripheral nerve by amyloid. The next clinical feature is anemia. The anemia are always normocytic and normochromic type, and it is due to replacement of normal bone marrow by the infiltrating tumor cells and inhibition of erythropoiesis by cytokines. Sometimes you can also say megaloblastic anemia, and it is due to either folate or vitamin B12 deficiency. Now, how do you diagnose this disease? Whenever there is a classic triad of marrow plasmacytosis of greater than 10%, serum and or urinary M protein, and lytic bone lesions, always the provisional diagnosis should be multiple myeloma in elderly patients. To diagnose, we have Durie Salmon myeloma diagnostic criteria, and it involves major criteria and minor criteria. Major criteria are plasmacytoma on tissue biopsy, bone marrow plasmacytosis of greater than 30%, M protein of predominantly IgG type, urinary light chain excretion of greater than 1 gram in a day in absence of amyloidosis. The minor criteria involves marrow plasmacytosis of 10 to 30%, lytic bone lesions, evidence of M protein but lesser than that described in the major criteria, and hypogammaglobulinemia of normal proteins. We require one major and one minor criteria or altogether of 3 minor criteria to diagnose multiple myeloma. However, these criteria are less used for multiple myeloma because it does not describe the prognosis of the disease. So we use international staging system. In stage 1, beta-2 microglobulin is less than 3.5 and albumin is greater than 3.5. But as the disease progresses, the beta-2 microglobulin will start to increase and albumin will start to decrease. There are different variants of myeloma cells seen in microscopy, and they are flame cells, Russell bodies, Mott cells, and Durie bodies. These 4 names are important for multiple choice question. Now, what are the investigations you'd like to send? You'll send serum ESR, you'll do the X-ray of the skull and other bones, you'll do the bone marrow biopsy, serum or urine electrophoresis, serum calcium, urinary routing and microscopic examination, and alkaline phosphatase level. Hypercalcium is associated with poor prognosis and it is important for MCQ. However, the bone scan is not useful in case of multiple myeloma because osteoblastic activity is suppressed. This is also important for MCQ. Management: if the patient is asymptomatic with no evidence of end organ damage, then no treatment are necessary. But if there is the presence of clinical features, then you need to treat by giving the immediate support. High fluid intake for renal impairment and hypocalcemia, analgesia for bone pain, bisphosphonate to delay skeletal events, allopurinol to prevent urate nephropathy, and plasmapheresis for hyperviscosity. We can use the drugs like thalidomide and bortezomib, which are the first-line drugs. Thalidomide plus melphalan plus prednisolone are used more often in the older patients. Hematopoietic stem cell transplantation can be done. And radiotherapy can be done for the bone pain that are not responding to analgesics and for the pathological fracture. Now let us discuss some MCQs. All the following are seen in multiple myeloma except visual disturbance, bleeding tendency, proteinuria, dystrophic calcification. The answer is dystrophic calcification. No doubt visual disturbance and bleeding tendency and proteinuria are seen in the multiple myeloma. But dystrophic calcification is not seen. To understand what is dystrophic calcification, you need to first of all understand the term pathological calcification. Pathological calcification is the abnormal tissue deposition of calcium salts. They are of two types. One is dystrophic calcification and the other is metastatic calcification. Dystrophic calcification is encountered in the areas of necrosis and it is not associated with hypercalcemia, whereas metastatic calcification may occur in normal tissues because of hypercalcemia. In multiple myeloma, we can see metastatic calcification, so the dystrophic calcification is not. Next question is, true about myeloma is all except plasma cell clonal proliferation, commonly seen after 50 years of age, amyloidosis can occur, and protein cast in urine are made up of complete IgG chains. Of course, amyloidosis can occur in myeloma, and they are seen in elderly population, and it is the plasma cell clonal proliferation. The protein cast in urine are not made up of complete IgG chains. They are made up of only light chains, since the complete immunoglobulin chain cannot be filtered by a glomerular basement membrane. Next question is, an elderly male presents with headache, recurrent infection, and multiple punched out lytic lesions of X-ray skull. The investigation that will help in establishing a diagnosis is protein electrophoresis, serum calcium, alkaline phosphatase level, and acid phosphatase level. Now always remember that to diagnose multiple myeloma, there should be classic triad. The classic triad includes marrow plasmacytosis of greater than 10%, serum and or urinary M protein, and lytic bone lesions. For lytic bone lesions, X-ray of skull has already been done. For marrow plasmacytosis, you need bone marrow biopsy, and the bone marrow biopsy is not present in the option. And for the serum and urinary M protein, you need to do protein electrophoresis, and since this is the only investigation that is given in the option, the answer is protein electrophoresis. Next question is, in multiple myeloma, following are seen except raised anion gap, lytic bone lesions, polyarticular pain, and M spike. Of course, M spike can be seen. There is polyarticular pain in the multiple myeloma. There is also the lytic bone lesions in the multiple myeloma, but there is no raised anion gap in multiple myeloma. So the answer is raised anion gap. To understand this, you need to first of all understand about the anion gap. Normally, our body does not have anion gap. The amount of cations present in the body is always balanced by the amount of anions present in the body. But we are measuring the anion gap only via few parameters of sodium, chloride and bicarbonate. Since there is always the difference between the chloride and bicarbonate level with the sodium level, therefore we can get the anion gap of 8 to 12 milliequivalent per liter. In case of multiple myeloma, since this M protein are cationic, to balance this increase of cations, the body will produce anions, and it is done by increasing the amount of chloride. Now, since the amount of chloride is increasing, therefore the difference between sodium and chloride plus bicarbonate will decrease. So in case of multiple myeloma, anion gap will decrease. Next question. A patient of multiple myeloma presents with bone lesions. What is the best marker for prognosis of the disease? Always remember that beta-2 microglobulin level is the best marker for prognosis, and it is the part of international staging system that we have discussed earlier. Thank you.